There are a lot of myths about antidepressants, especially that they are simply terrible drugs that cause addiction, that you can become even more of a psycho than you were before they were prescribed, that if a person is prescribed them, then the person is mentally abnormal, because after all, these are antidepressants, which means depression, which means the person is mentally abnormal. Let's discuss in this video whether antidepressants are really such terrible demonic drugs as they are portrayed, what evidence there is, what counter evidence, especially in the treatment of insomnia. Watch this video to the end, and I will tell you when there is really no indication for antidepressants, especially in the case of insomnia. I want to start with a joke. A patient comes to the doctor, says, "Doctor, I'm going to hang myself tomorrow, or I'll drown myself." The doctor says, wait, well, stop. Let's discuss this. What happened? He says, well, you understand, I have a problem. I pee everywhere. Sorry for such a word on air, but as they say, you can't throw words out of a song. I woke up, heard upsetting news, and wet myself. Well, that's half the trouble. I came to work, the boss offered me a new good position, and I peed myself out of joy in front of him, so I didn't get the job. Well, in the evening, I met my beloved girl, proposed to her, she said yes, and I peed myself right in front of her, and that was the end of it. So what remains? To hang or drown myself. The doctor thoughtfully suggests a good solution. Here are your pills, come back in a month. A man comes back in a month, says, "Doctor, you've simply performed a miracle. I'm now living a full and happy life. I have great prospects. Everything in my life is wonderful. I pee everywhere, but I absolutely don't care about it." That's what the effect of antidepressants can be like. Although, of course, any idea can be taken to the point of absurdity, but generally speaking, there is a good sense in every, so to say, joke. This precisely pertains to antidepressants. If you like this joke, please give it a like. Let's start with the very name antidepressants. So overall, I think those people who came up with this name for a class of drugs, they were somewhat mistaken, I would say. Because in the very name, there is some stigmatization of patients that if they are prescribed, then you have depression, and therefore you are mentally abnormal. Like hypnotics, tranquilizers, even neuroleptics, or some kind of anxiolytics. It's some kind of name, yes, it's medical, but it doesn't carry the so-called negative connotation. That is, a person does not feel mentally abnormal. As soon as you mention an antidepressant, a person thinks that's it. It's some kind of catastrophe. I'm mentally abnormal. In fact, it's not like that at all. If we talk about the use of drugs for insomnia, especially chronic insomnia, then antidepressants, if they are prescribed according to the appropriate indications, turn out to be the most acceptable and safe drugs. Because, for example, physical dependence develops with sufficiently long-term use of hypnotics or tranquilizers. And if we read the instructions for the use of hypnotics or tranquilizers, it is written there that they cannot be used for more than a month. If we take neuroleptics, yes, they can be used significantly longer, but their safety profile, I would say, is so-so, to put it mildly, and the number of possible side effects exceeds the number of side effects that modern antidepressants have. That is, if pharmacological treatment of chronic insomnia is necessary, and especially if it is combined with anxiety and depression, then this so-called drug of choice, or first line of treatment, allows to effectively cope with both insomnia and anxiety and depression. That is, we solve all these problems with one drug, but there is a certain peculiarity of application here. For example, if we primarily see problems with sleep, there are antidepressants with a sedative effect. I'll now list different names, be they international or commercial. The only thing I have to say is that, naturally, if the question of prescription arises, there are contraindications to prescribing these drugs, and you need to consult with a doctor. So, if we talk about a group of hypnotic drugs, for example, trazodone, triticum, this is mirtazapine, and various others, so to speak, names. Well, there are brand names, there is Liravan and so on, Mianserin and so on, and so on. That is, there is a category of antidepressants that give an antidepressant effect and a hypnotic effect. They are prescribed in the evening before sleep. And here there is sometimes even a mistake when a patient with insomnia comes to me, and I find out that he was prescribed an antidepressant, which, in general, well, such, I would call, or with a balanced or even with an activating effect, well, for example, Prozac, which is directly written in the instructions that it can cause insomnia. Maybe I, of course, understand that a person was given a drug and probably thought that if we remove anxiety and depression, then sleep will normalize itself. But in this situation, it is better to prescribe an antidepressant with a hypnotic effect. which will give both an antidepressant and a hypnotic effect, and an anti-anxiety effect in particular. Sometimes there is a need if a person, for example, feels anxiety during the day, a decrease in mood, and so on and so on, and a night antidepressant is not enough to also provide the appropriate effect during the day, to prescribe drugs with such an activating, balanced action in the morning. For instance, escitalopram, Cipralex, sertraline, Zoloft, and all their possible equivalents. And in this way, we achieve on the one hand an antidepressant sleep-inducing effect with the evening antidepressant, and correspondingly an antidepressant, and to some extent activating effect with the morning antidepressant. Such patients achieve a good effect with these drugs, which I reiterate, are prescribed based on indications. At the same time, what is extremely important, and when a mistake is sometimes made, a person can get a good enough effect, let's say, within a month or two, and already feel that he is practically healthy. But if at this moment a person thinks that's it, you can cancel the antidepressants, the likelihood of a relapse is practically 100%. That is, usually antidepressants are prescribed for at least 6 months, usually for 8 months, or even a year, sometimes even a longer period. Doctors should explain to patients that this is what a long-term stabilizing effect should be. And when everything is normal for a person for 6-8 months, then gradually cancel the drug. Well, you also need to see if a person is in some ongoing stressful situation. For instance, he has a demanding job, family issues, or health concerns. And if his stress continues, then in this situation, it's even better to postpone the cancellation of the antidepressant. Well, simply because the stress itself will eventually lead to a relapse. And in this sense, there's nothing scary if a person has been taking antidepressants for several years. They do not develop a physical dependence. And to fear that a person will become dependent, that it will be necessary to increase some dosages and so on and so forth, in this sense, there is nothing to fear. And as for complications, yes, they are possible. You read the instructions. Yes, complications are possible. But antidepressants practically do not have so-called irreversible complications. Even if some side effect occurs, well, in the end, you can reduce the dosage, you can cancel the drug. Indeed, we can handle this side effect. It will subside. What else is important to know, and what doctors also forget to inform patients about, is that antidepressants with a sedative effect have such a first dose effect. When a person takes a dose of an antidepressant, sleep may not have improved yet, but the next day, the person feels expressed fatigue, brokenness, and drowsiness. The person thinks, I'm not sleeping at night and not at all during the day. And there were a day or two when he took an antidepressant and quit. And he needs to go to the doctor in a month because, well, the doctor said come in a month. The patient comes in, says, doctor, so I quit on the second day, well, because it was somehow messed up during the day. Likely, it's a serious side effect. This is so-called first dose effect of antidepressants with a sedative effect. And it usually goes away within a few days, well, maybe a week to a week and a half. That's why it's necessary to gradually increase the dosage. If such an effect occurs, you may stay on this dose and slightly increase the dosage later, but again, after consulting with a doctor. And this suggests that if a person experiences this effect from the first doses, the antidepressant will be effective. And literally in a few days, the situation will start to improve, the night's sleep will become more stable, but we usually do not evaluate the full effect earlier than 3-4 weeks from the start of taking the antidepressant and gradually increasing the dosage. There is no instant effect here. It is also necessary to explain to the person that we are not like this. As the painkiller took from the head, the headache passed. The headache passed. You have to wait here. I've already said that stress is one of the main causes of insomnia, anxiety, depression, and then all this is a vicious circle because chronic insomnia itself further exacerbates anxiety and depression, and it's generally very difficult to get out of this so-called vicious circle. At the same time, there are very effective methods of treating chronic insomnia without drugs, in particular the so-called cognitive behavioral therapy for insomnia, which affects both insomnia and anxiety and stress. And I implement Dr. Buzanov's insomnia treatment program, which allows in a significant percentage of cases, well over 70% of patients, to cure chronic insomnia without drugs in a month and a half. Simply by stabilizing the nervous system, teaching a person to cope with stress, and this allows effectively dealing with insomnia. Read in the description to this video about this program. And if you have a problem with chronic insomnia, reach out. I can effectively help you. What else needs to be understood is that there are no clinical recommendations that would say that one antidepressant is better than another, say, a sedative. And sometimes this is not even a method of scientific poking or testing of drugs. That is, one works well for one patient, not so much for another, and vice versa. In this sense, perhaps, when we choose an antidepressant with a sedative effect, we look more at its side effects or possible complications from treatment, at the safety profile. Well, for example, in men, as a rule, I start with Tritic or Trazodone. This is a drug that urologists sometimes use for treating erectile dysfunction or potency problems. Well, and of course, if a man is young enough, then this is an important issue for him. And some other drugs can cause problems with erection, well, or with erectile dysfunction. They're reducing libido. In this context, yes, it's a primary drug. Regarding women, there's also a question, for instance, on prescribing mirtazapine. Especially if a woman has an excessive body mass, it can potentially slightly increase the body mass. If there's no issue, you can begin with mirtazapine. If this is a problem, it's better to also look at antidepressants with a primary effect, well, with some, so to speak, different profile of these possible side effects. But I want to say that both the doctor and the patient need to be prepared for such a sufficiently, perhaps even sometimes lengthy work. There are even such, works that show that if you prescribe one antidepressant, the probability of a positive effect and achieving a clinical effect is somewhere around 70%. But if it didn't work, we cancel it, prescribe the next one, and if we try 2-3 antidepressants, the probability of a positive effect will already be 90%. That is, sometimes it's such a complex enough process over several months of selecting your so-called antidepressant with a dream effect. As for the morning activating antidepressants, they have a slightly different effect of so-called first doses. A person admits to feeling anxious and experiencing a decrease in mood. A person is prescribed an antidepressant, and then the anxiety gets worse. The person said, I was anxious, they gave me a drug, and I became more anxious. And here, too, is the art of the doctor to explain to the patient that this is a possible side effect, and also a known situation that within a week or 2 or 3, the anxiety state may worsen. And in this sense, we sometimes cover up. There used to be such a so-called phenazepam bridge, when the drug phenazepam was prescribed. And now, for example, hydroxyzine or Atarax is prescribed to remove some additional degree of anxiety. And then, after 3 weeks, these drugs are removed, and the antidepressant itself fully possesses the anti-anxiety effect, although at first, it even somewhat exacerbated it. In this sense, I want to say that this is some kind of art to put a person to sleep on one hand, yes, with the use of an antidepressant, and on the other hand to ensure his normal daily functioning. Therefore, if you came to the doctor and the doctor assessed the clinical situation and said that you need antidepressants, do not think that the doctor perceived you as just a mentally abnormal person or that you are a mentally abnormal person. This can be prescribed for ongoing stresses, which in turn cause, for example, reactive depression, anxiety, but this is as a reaction to stress, especially ongoing stress. There's a terminological confusion. We have psychiatric depression, which operates under its own laws within the context of bipolar disorder, manic depressive psychosis, previously known as recurrent depression. These follow their own psychiatric laws, if we can call it that. And there is a reaction of the nervous system to a chronic stress situation when depression also develops. In this situation, the use of antidepressants is very effective in dealing with problems in patients, bringing them back to normal life, and even despite some stressful situations, the quality of life of a person significantly increases. If you have been prescribed antidepressants, describe your feelings. Did you have this first dose effect if you were prescribed antidepressants for the night? Did you get up badly in the morning? Was there a breakdown? Or did the anxiety intensify if you were prescribed morning antidepressants? In general, your feelings. Yes, did the antidepressant help you? Well, maybe I will participate in the discussion to some extent. The only thing that, of course, I will not recommend there, just in the discussion of prescription or cancellation of drugs. It should be a treating doctor, but some general principles can be quite discussed. Yes, antidepressants need to be phased out. This is practically a golden rule. Different antidepressants, so to speak, with different speeds, but mainly it takes no less than a month and even 2, because abruptly quitting can be such a withdrawal phenomenon. But it's not the classic withdrawal phenomenon, that the antidepressant just stopped working. Everything will come back to you again. These are rather different vegetative manifestations, while there is simply a tremor in the body, dizziness, headache. As promised, I'll tell you when it's inappropriate to prescribe antidepressants. But I want to emphasize once again that the treating doctor should evaluate each specific patient. If we have acute insomnia in response to some stressful situation, and there is no expressed anxiety, no expressed mood reduction, I would say that if a person in this situation turns to a neurologist or even a psychiatrist, then I see that sometimes there is an excessive prescription of antidepressants. That is, they immediately give the person pills. I'm just recalling a specific example. A patient comes to me who gets an activating antidepressant in the morning, and in the evening, even a neuroleptic, quetiapine, a quite serious neuroleptic. But anamnesis, he started having problems with sleep a year ago. He was seen by 2 neurologists, and they prescribed some treatment of their own, which was not very effective. His sleep problems persisted. Then a psychiatrist sees him and makes his own psychiatric diagnosis of an anxious depressive state. In the morning, an activating antidepressant, and in the evening, a neuroleptic, quetiapine, as I said. The patient started to sleep a little better, but still has trouble falling asleep. And I like to ask a person about their anamnesis. Typically, my consultation takes an hour and a half. Turns out a year ago, he started working remotely. And there, first of all, he started such a monotonous lifestyle. He began to lie in bed. He just started working in bed. That is, his bed began to be associated not with sleep, but with work. Next, he bought a coffee machine and started drinking 8-10 cups of strong coffee a day. And for some reason, he started sleeping poorly, not associating one with the other. And the 3 doctors who saw him before this did not bother to ask what his lifestyle was like. And I will say that in a significant percentage of cases, with some acute insomnia, or not very long-lasting insomnia, we need to start not with the fact that we immediately prescribe drugs, but with the analysis of the lifestyle. Perhaps the individual significantly cut back their load or stopped participating in sports for some reason, I'm not sure. Perhaps his routine was disrupted, leading him to sleep in on weekends. Switching to remote work completely altered his day and night. In a significant percentage of cases, in 50%, we can, before we prescribe any drugs, particularly antidepressants, simply by normalizing lifestyle, sleep hygiene, significantly improve or normalize sleep in another 50% of patients. We start with the basics, with lifestyle, sleep hygiene, and bedroom. In this case, I favor the saying, there's no need to use a cannon to kill a sparrow. And the second situation, which doctors can also often mistake, is another specific example. The man says, I had such a heavy breakdown 5 years ago. We were getting divorced for half a year, dividing the property, and I had the worst insomnia. Since then, I've done it all. Wedded, had kids, built a house, planted a tree, works great, but my insomnia only worsens. And they prescribe him antidepressants, neuroleptics, a combination, and the man comes to me on high doses of drugs. And I understand that this is so-called conditioned reflex insomnia. In the background of the divorce, he tried to sleep all these 6 months. He couldn't. He formed a conditioned reflex of fear of not sleeping, and bed insomnia, negative forecasting, oh, I don't sleep and I won't sleep further, maladaptive behavior. He started to lie in bed 3 hours longer in attempts to fall asleep, which even more impaired sleep. That is, his insomnia is already conditioned not by some stress, which has long ended, but by fixed conditioned negative reflexes, negative thinking, and maladaptive behavior. This is the so-called classical conditioned reflex Pavlovian model of insomnia development, in which drugs do not work very well. And the most effective is cognitive behavioral therapy for insomnia. I, in fact, already mentioned my own insomnia treatment program, which I implement. I apply these cognitive behavioral principles, which allow very effectively, literally in a month and a half, to cure a patient from such insomnia without drugs, or even canceling those drugs that were prescribed before by other specialists. Generally, it's better to avoid drugs in this situation, instead using cognitive behavioral therapy for insomnia. Subscribe to my channel. There are a lot of interesting videos here about sleep hygiene and about the bedroom, and of course about some problems with sleep, about insomnia too, as you can see, videos. And click on the bell so you don't miss my newest and most interesting videos.